Yeah. Yeah. That's awesome. Awesome.
Okay. Pete, if you can have somebody grab one of the Capers folks to help us out on this, that'd be helpful, please. Thank you. So we're going to keep moving forward here, Commission. Any other comments? Or are we ready for a motion? Commissioner Kane.
Deja vu.
I would like to make a motion that we move forward with the ITDM contract
For 3 years.
for 3 years.
Okay, you've heard the motion. Is there a second? Is that a second, Commissioner? Second? Getting the thumbs up. So we have a motion and a second. Is there discussion on the motion? Any discussion on the motion?
It's going to be interesting.
Okay, hearing none. Commissioner Kane.
Aye.
Commissioner Deckent.
Aye.
Commissioner Gossage, I don't believe is online. Commissioner Hensley.
Aye.
Commissioner Sutton. Commissioner Schmidt. All right, motion carries. Committee, we're going to stand at ease for a few minutes until we can try to figure out the audio.
Yeah.
Yeah, sir, we have audio now. It's going. It's piping out online.
The issue is it's piping in-house as well on a 10-second delay. All right, I'm going to speak into the microphone to test to ensure that folks online are able to hear, and also I'm going to stop talking for 10 seconds to make sure there's no delay in the room. I think we're in good shape here. So I'm going to test this one more time. We have a commissioner on the phone with a staff member. So here in about 10 seconds, we should know if we're still available online. Yeah. All righty, we are going to come back to order, and I apologize to everybody in the room and online. Hopefully, we've got everything worked out. Thank you, team, for working through that. Just to make sure we recap for those that are online, we call ourselves to order. We approved the minutes from the August meeting. We just wrapped up approving the MAP, the membership administration portal contract for the next 3 years, and I think we're in good shape. And so we are ready to move on to the next agenda item. So with that, we were going to talk about the EAC appointments. So I would invite Michael London to come up, and hopefully the microphone works. And if you can introduce yourself for those online, please.
Hello, I am Michael Lundin. I'm the president of the EAC. Do we have a slide? Thank you. We've, over the past several years, yes, can you hear me? Over the past several years, seen some attrition in our membership due to retirements and resignations for people leaving to go take other positions. And so we've had a very successful recruitment drive for new members, a wealth of very qualified candidates, and our committee for membership has reviewed many applications and come up with a list of recommendations for 7 new members to fill vacated positions, including 1 retired member. There is a open retired member position, and an additional 3 reappointments of current members who are up for renewal. I will refrain from butchering their names, but you can see them in the memo. So I would ask, obviously this is a recommendation to you guys, I would ask for your approval of those new members.
Very good. Thank you very much. Commissioners, any questions? Commissioner Decken.
Remind us, please, the total membership number of the EAC is?
I believe it's 21.
Okay.
Any other? Commissioner Schmidt.
I move to approve the recommendations for the 7 new members and also the reappointment of the 3 members.
Second.
Okay, we have a motion. We have a second from Commissioner Hensley. Any discussion on the motion? Hearing none. Commissioner Kane.
I was just going to offer a second. I was too slow.
Yeah, we're voting on the motion now. So Commissioner Kane.
Aye.
Commissioner Decken.
Aye.
Commissioner Gossage is not here. Commissioner Hensley.
Aye.
Commissioner Sutton.
Aye.
Commissioner Schmidt.
Aye.
All right, motion carries. Thank you very much.
Thank you, commissioners.
All right, that concludes the action items component of the meeting. We're going to move on to discussion items. So Director Flory is going to walk us through the open enrollment report from this last open enrollment session. We should be on tab 4.
Okay, Pete, can we advance one more? So we did complete another open enrollment successfully. On the next slide, we're going to look at the active employees starting here. So you can see on the slide, we've shown you the plan year 2025 enrollment in the middle column, and on the left of that is the plan year 2026 enrollment. And for the most part, except for 2 items, we have seen increased enrollment. We did see a few less select the mass transit benefit, but a few more picked up the parking. And then when you look at the HRA, we have a fewer number of members this next year, just a slight reduction in the number of members who elected to have a health reimbursement account. We did see that the number of individuals with a health savings account increased. So we're going to look at these numbers in more detail in just a minute. We did also see a slight increase in the number of employees who did not go out. They were currently enrolled in plan year 2025 and in 2026 didn't take action, and so they will be defaulted to plan N. We had a few slight increase in the number that defaulted. So on the next slide, open enrollment began October 1st and ran through October 31st. Our staff conducted 7 virtual personnel officer training meetings, and those were available to the HR staffs of all the state agencies, the non-cabinet agencies, and the non-state public employer groups. We held 2 benefits fairs at the Capitol. We held one outside and one in the Rotunda. We had 4 live open enrollment webinars, and staff conducted 44 open enrollment meetings in 24 cities throughout the state. In addition, on our website, we have a video of the open enrollment presentation that was available 24/7 to any employee who wanted to watch it. We also had vendor-specific videos available on our website, as well as the open enrollment book. So on the next slide, we're going to look at a summary. For the state employees, you'll see we had 35,503. On the non-state public employers, we had 3,189 enroll. Plan A has the highest enrollment with 19,462, followed closely by Plan C with 16,282. Plan J, you'll recall, this is the plan that is specifically designed to meet the needs of an individual who's in this country on a J-1 visa. It is available to any employee who wishes to enroll in it, but because it is a little bit unique, it is expected that it has a small enrollment. And then Plan N is our most affordable product, has the lowest premium, but does have some additional out-of-pocket costs. So that enrollment is at $2,380. On the next slide, you can see the breakdown between Blue Cross and Aetna. Aetna has 4,372 contracts, which is a slight increase over their current number, and Blue Cross Blue Shield has 34,320. And on the next slide, you can see that breakdown. We had 546 individuals who had Aetna move to Blue Cross, and 402 who had Blue Cross who moved to Aetna. On the next slide, you can see the enrollment by the different plans broken out. So you can see how many people took Blue Cross and how many people took Aetna for each of the plan offerings. On the next slide, we break it down so that you can see what type of contract did the employees take. And again, the vast majority have enrolled in employee-only coverage, followed by employee children, family, and finally employee spouse. And then we break down on the next slide the dependent numbers a little bit further and show you the state versus the non-states and how many our spouses are covered and how many children are covered and the totals for all dependents covered. On the next slide, we have the dental. Dental is, you can elect that separately from medical. So an individual who maybe has coverage somewhere else for medical can elect to have dental. We had 39,528 contracts in the dental. Our voluntary prescription eyewear insurance. This is a voluntary plan that is the premium is entirely paid for by the employee. We offer 2 options, a basic program and an enhanced plan. The big difference is the enhanced plan has a better coverage if you are using bifocals, particularly your no-line bifocals and some of the higher cost lens options. And it is always the most popular with 22,728 people selecting it. The voluntary insurance coverage, these again are entirely employee paid contracts. This is insurance that is available. We offer an accidental injury plan, critical illness, and hospital indemnity. And over the last few years, we've seen the popularity of these particular options continue to increase. On this next slide, we look at our account-based programs. So for individuals on Plan C and Plan N, the health savings accounts, we have 17,336 is the most popular option, and only a few folks have selected the HRA at 1,330. We also offer the flexible spending accounts, and this allows our employees to set aside money pre-tax from their check in order to pay for healthcare expenses. The healthcare FSA can be used by individuals on Plan A and J, as well as individuals on Plan C and N who have an HRA. So that is the most popular of the accounts, with 6,532 members selecting it. For an individual who has an HSA, they are limited to having a limited purpose FSA, which covers dental and vision expenses. Dependent care is for individuals who have children that are getting daycare type expenses, and they can set aside pre-tax premium dollars to help pay for those child care expenses they're incurring. The commuter benefit, we have two different options within this. We have a parking option that allows our employees who are parking in mostly public lots or privately owned lots close to their offices to set aside the cost of that parking out of their check pre-tax. The mass transit allows the individuals, particularly who use public bus services or on the state van pools, can set aside their costs for those transit costs using that mass transit benefit. And on the next slide, again, this is about the individuals who got defaulted to Plan N. These are individuals who were enrolled for coverage in plan year 2025, but they 2025, but they did not go in and make a selection for plan year 2026. So they would have been moved to Plan N. If they were enrolled with Aetna, they remained with Aetna. If they were with Blue Cross, they remained with Blue Cross. Plan N is our most cost-effective program, lowest premium for those individuals, and they are set up with an HRA. So this year we did have 347 individuals that got defaulted. 96 of those were already enrolled in Plan N to begin with. And we had 307 of them were state employees and 40 of them were non-state public employees. And with that, I'll stop with the active, and Secretary, you can give me direction on how you want me to go forward on the direct bill. Do you want to go through all of that, or
Yep.
what's
Why
your
don't we
preference?
pause here and see if commissioners have any questions on open enrollment? Commissioner Smith.
Thank you, Mr. Chairman. On the last slide on page 34, the employees defaulted to Plan N.
Mhm.
I don't think this reads as clearly as I think it should. On the first bullet point, well, the second one under the employees not enrolled that were enrolled in plan year, the first bullet point, members were enrolled into the same healthcare company, Aetna or Blue Cross Blue Shield of Kansas. I get that. And the same coverage level, because that isn't really the same. If they were enrolled in A, we didn't re-enroll them in A, they moved to N.
So let me clarify what we meant by coverage level. What we mean by coverage level is if you had family coverage this year, we defaulted you to Plan N with family coverage next year. We didn't reduce the level of your or the eligible members covered. So that's what we intend by that. So we could work on how we phrase that.
Okay.
But that's what we mean, is
Okay.
that if you had someone covered, you didn't lose coverage for that person.
Okay, I understand that. Thank you.
Any other questions? Commissioner Decken.
Just several. Excuse me. Any idea how many employees attended either the live or video open enrollment presentations that were made? I don't necessarily need a direct number, just get a kind of
Yeah.
sense of how how well or slimly that was utilized.
So if I roll back here to the the annual report, we do have a section in the annual report. Let me see if I can.
So you're going to call me out for not having read the annual report closely enough, huh?
So in here, we talk about open enrollment, and over 500 members attended the first event outside the Capitol. The second event in the Rotunda saw over 350. The staff had 44 meetings at 31 locations in 24 cities. These meetings were attended by 2,700 members in total. Does he tell me the number?
Okay. No, that gives, well, at
Yeah.
least for me, that gives me a pretty good idea. So pretty good attendance the way it sounds.
Yeah. So it actually is summarized for those of you who have the annual report. It's on page 114.
Okay.
Sorry.
For years, our enrollment in Aetna has been a small percentage of the overall enrollment. That doesn't cost us, that is the healthcare system anymore to have two separate companies involved, or what cost, if any, are there to us as the
So we view it as a benefit to
Right.
having two vendors because it allows us to, like, for example, right now we have an issue here in the city of Topeka that Blue Cross and Blue Shield and one of our main hospital systems, KU campus of St. Francis, have not reached an agreement on a contract. And we do have that campus covered under Aetna. So employees were made aware that if they were concerned about having that coverage, that it would be available to them if they chose to enroll in Aetna. And keep in mind that Plan A is Plan A. It doesn't matter whether you get it from Blue Cross or Aetna. The coverage is the exact same coverage. The difference is the network that they have available. So we see that as one of the big benefits. It really doesn't create a lot of extra work to have two vendors because the plan design is the same. If the plan designs were different and we had to administer different programs with the different companies, that would be more challenging. But this is, when I started with the health plan, I think we had 12 companies. We had like 3 PPOs and we had like 8 HMOs. So by comparison today, this is pretty easy peasy stuff.
Okay. And it's not, I don't have a ulterior motive couched in that. Just kind of struck me as you were going through things. And by the way, Hutchinson had an issue with Blue Cross and the health clinic there that has been resolved, but same kind of thing existed for a while. Dental must be maintained. If I drop dental, I'm not going to be able to get back in again, correct?
As a retiree, that is a correct statement.
Well, I wasn't even, but how about as an active?
As an active employee, they are allowed to pick every year during open enrollment whether they want to maintain dental coverage.
Okay. So as an active, I can dip in and out of dental coverage as I desire.
Yes. We don't see a lot of people actually doing that. Most people, the dental program is a very good program, and they want to go get their 2 cleanings per year because they also get their credits for their Health Quest by getting their dental cleanings. So that's an easy way to get some credits towards your wellness benefits. So we don't see a lot of movement in that, and the disconnect between dental and medical was really more about allowing individuals who particularly had medical coverage either through a former employer, the federal government, or through VA benefits or somewhere, to be able to select our dental plan. And that was a big request we got.
What I noticed is there's about 1,000, maybe 800 more folks enrolled in dental than there is in the medical.
Yeah.
What are the costs are there costs to maintaining the flex spending accounts, or are the costs basically on the setup when they're created, and then the maintenance just is an ongoing thing with little or no cost?
Is there a fee for the FSAs? Yeah, there is a fee for the FSAs for the setup this year, But next year, when MetLife takes it over, you remember they had no fees when you voted on that contract, so there will be no fee for it. The other big benefit to the state is that when the employee elects to use those pre-tax dollars, it reduces the employee's taxable income, but it also reduces the state's FICA tax. So that's the benefit to the state, is that reduction in taxable income also reduces the FICA tax, which has been a huge benefit to the state.
Thank you.
Commissioner Schmidt.
Thank you, Mr. Chairman. Has staff ever done a side-by-side comparison on Aetna and Blue Cross Blue Shield on what you say are the same exact benefits?
Well, the benefits in the benefit description are exactly the same. There may be some cases where, if it's such as a situation where you're looking at a surgical procedure, that Blue Cross may not consider that to be, the standard of care, and Aetna may, because they do have their own medical experts on staff that would come into play. But as far as the benefit main structures, they are the same.
Well, I know of an example where I don't know whether it wasn't a surgery, but it was a treatment where the one plan covered it and the other plan did not.
And that could be because of they each have their own medical criteria that they use for making decisions on particularly on services and what is the standard of care. They each use their own experts to determine that.
So I think that would be I think that would be important for our employees to know but when they enroll, what does Aetna cover and what does Blue Cross Blue Shield cover? Because they aren't the same.
Unfortunately, I don't know that that's going to be something that's going to be easy or maybe even possible to compare, because there are so many procedures that potentially might be impacted by those types of medical decisions.
But then I don't think we should say they are exactly the same,
Okay.
because they are not the same.
But the base structure of the plan is the same, but potentially there is variance on what they considered standards of care and what services might be considered experimental or investigational. Yes.
So I think we need to put that caveat in it when we say that, because they're not.
Okay.
Okay, thank you.
Any other questions or comments? Okay. Jennifer, why don't you just very quickly just hit on the highlights, if you would, for the direct bill over the next couple of pages.
Yeah. So Pete, can we go forward to direct bill? So non-Medicare eligible members enrolled through the direct bill program. We had one big difference between direct bill and active employees. Active employees, we have active enrollment. That means you have to go out and make an active election or you get defaulted to Plan N. With our retiree population, their coverage rolls from year to year unless they actively decide to make a change. So if I am a non-Medicare eligible person and I am enrolled in Plan A and I don't want to make any changes, I don't have to do anything and my coverage rolls forward. So the numbers showing here are the individuals who actually went in and made some sort of change during this open enrollment. So for clarity, these are only folks who made changes. And there were 499 of them, and you can see that Plan C was the most popular option that they changed to. So let's go forward. So here you can see for our Medicare eligible population, again, these individuals don't have to make elections, but this breaks out the total contracts here. You can see that we had 6,677 who are enrolled now in Medicare supplement insurance, and we have 749 who have elected a Medicare Advantage plan. Direct bill members do have the right to go in, and if they are covered under a Medicare supplement plan in 25 and they want to move to Medicare Advantage in 26, they can do that. Conversely, if they are enrolled in a Medicare Advantage in 25 and want to go back to a standard Medicare supplement plan, they can do so during open enrollment for plan year 26. They have the same rights that an active would have with regard to covering their family members and making elections about their coverage. And I think I'm not back. Let's go one more, Pete, and see where we're at. So this just shows you, this is how many of our direct bill members have elected dental. We have 8,216 contracts in the dental. Of our direct bill members, 5,027 have elected the prescription eyewear coverage. So I think that pretty much covers direct bill. There's additional information further back if you want to see what the numbers look like year to year between the plans. We have all those slides in the back for you.
Thank you. Any questions on direct bill? Commissioner Schmidt.
Thank you, Mr. Chairman. So what I'm wondering is, I did not realize this until recently, but if a 65-year-old retires from the state of Kansas and goes on Medicare, but has a younger spouse that is like 60 years old, and they still want to have insurance, that spouse can enroll in our state employee health plan, right?
As long as the Medicare eligible person is covered by the state employee health plan, then the non-Medicare spouse is also eligible to be covered under the state employee health plan.
What I don't understand is why does that non-Medicare eligible spouse, why are they allowed to join at the employee rate? Because one of the big deals that we've had discussions on ever since I've been on this commission, seven years now, is that the spouses are the expensive ones, right? I mean, that's what Siegel tells us, and that's what we read in everywhere. So why would we allow them to enroll as an employee and not as at the level of the spouse, of the employee plus spouse level?
So when a member becomes Medicare eligible and they are not an active employee, the decision was made that we would move all of those members, whether it's the employee or the spouse, whoever is Medicare eligible must pick a Medicare product. So we split the enrollment. So we set it up so that we track them together, but the Medicare person picks from the Medicare column and the non-Medicare person picks from the direct bill non-Medicare products. They pay both the employee rate and the employer rate. It's a combined rate. It's not, they don't get it for the same price that you get your coverage as an active employee. That spouse would be paying the full cost of the insurance. Just like an employee who retires pays the full cost of the insurance.
But
Yes.
but we set the other plans up that your spouse is, if you want to cover your spouse, it's a lot more expensive than just the employee only. So I'm just asking, I would like to revisit why we allow these non-Medicare spouse to enroll at the employee level.
We would have to look into and work with Siegel if that were to be something the commission wanted to develop separate rates so that employees and spouses pay different rates as direct bill. Yeah. So I don't think I have a better answer because that's not something
you-
we have.
Could you
today.
could you do the research to tell us,
We can-
how did that come about?
So the commission did vote to go back up.
We might be better served if you're okay to maybe put a pin in this and have some
Yeah.
offline conversation to make sure that we're getting to the
100%, yeah.
right.
Yeah.
But I think it's
Yeah,
important because
complicated.
I agree. What I don't want to do is get into speculation if we're crossing wires on what we're talking about. So if we can connect offline, Commissioner, and then we can make sure that
Well-
we follow up at the next meeting to determine.
We can.
I just
I'm not trying to kill the conversation.
No. I just would request that we have that everybody gets some answers on that as to how we arrived at that decision.
Yeah, so we'll have Jennifer connect with your staff and make sure that we're answering the right question, and then the team can do the research and come back to the next commission meeting.
And then also, if you can delineate out the cost of the non-employee being in the employee category.
We'll pull
So-
everything that we can.
Yeah. I have questions, so we'll connect and see if we can't find some answer, because I don't think I followed that.
Yep,
We'll get there.
cover it offline and come back
Yep.
publicly. Commissioner Decken.
I have one comment, and the questions asked by Commissioner Schmidt reminded me, and even though this is years back, I remember when I made the switch from direct bill non-Medicare to direct bill Medicare, and that's pretty seamless for me. There's not a big age difference, but there's an age difference between my wife and I, and it really caught me off guard. Now I got the coverage that you're asking about, but I guess what I'm suggesting is, and I'm not sure the where, I guess probably to the employee when he or she is going from direct bill non to direct bill Medicare, to say to them, if you have a spouse who is younger or something, be aware he or she becomes a non-insured on your plan unless they make some other arrangements. I just remember that being kind of a hectic and a concerning period of time for me in that first month or so preceding, to make sure I got all the T's crossed and I's dotted to keep her covered.
Yeah.
So, because it wasn't clear to me at that point that we were basically, I mean, it makes sense, but I didn't anticipate that when I became Medicare eligible and had my own plan, that my wife was then separated.
Yes.
And
split the
I
contract.
had to make arrangements to cover her, whatever those arrangements were going to be.
But we
I'm
would
just saying I
have,
was caught unawares.
yeah.
And so I guess saying to the folks, even if you're an active employee, I guess, if you're older than your spouse, you basically get your own plan, and your spouse has got to have his or her own plan as well.
Not as an active, because
Active.
as an active employee under federal law, we cannot treat a Medicare person different than we would treat any other active person. So under the active plan, if someone continues to work past Medicare eligibility,
No, I'm talking about
Medicare.
going to retired.
For direct bill, that would be, for direct bill, we do split the contracts. The spouse is still an eligible person. They are split to, the Medicare person takes the Medicare plan, the non-Medicare person takes the active plan, and they're billed separately. I believe, aren't they, Mike? Yes.
Probably so.
Billed
I
separately.
may need to take a look at what I
Yeah.
see, but I recall that time. Okay.
Yeah.
And I mean, it worked out, but I recall it being an anxious time for a bit, because I was caught unawares that my moving to this other status separates her from what we'd been doing.
Right.
And so I had to, maybe there's something that can be put in the information for that.
We'll look at that.
Throws up a
Yeah.
flag for people.
We'll look at, see if we can, we recently, this summer, we worked on separating out we have for employees what's called the employee guidebook. That's kind of the rules of the road of the health plan for an active employee. And in there, we had kind of dredged in parts, put information for direct bill people. And this summer, we actually split those books apart, and we made the active book strictly address active issues, and the direct bill book be more specific and more detailed to provide our direct bill members more information about how to navigate once you become a direct bill member. So we have tried to enhance that, but we can certainly go back and look at it.
Thank you.
Yeah.
All righty. Seeing no other discussion, Jennifer, I'm going to throw a curveball and just reference in the appendix B is the annual report. Since Jennifer mentioned that already, that is what we will be submitting to the legislature in January, as is required by statute. So just want to draw your attention to that. If you've had a chance to read it or not, that is what is going to be going in front of the legislature from the commission. That'll be signed and delivered at the appropriate time. So, all right, moving on to the financial report. We're going to have the folks from Siegel come up. Before they jump into the financial report, I believe Ken is going to discuss they're making some staffing changes at Siegel and shifting around the team. So Ken's going to couch that for us and walk us through that.
Hey there.
You can
Thank
identify
you,
yourself for
Mr.
those online,
Secretary.
please.
We on? Okay. First off, I want to thank the commission, the staff, everybody's been a pleasure working with you guys for all these years. I first started working with you in 2015. It's now our 4th contract. So not only do I value it, but Siegel greatly values our partnership with you. That being said, over the course of time, of course, companies want you to do more roles, more responsibility. So I've been asked to take more of a new business role for the East region. So I'm going to, for your account, I got to be more involved as an executive sponsor on the role. So I'll still ultimately be responsible for your account. But we're going to have a new person involved as doing the day account management. So that's Kirsten's here today. She's going to address you in a couple minutes, but Kirsten's got tremendous experience. She's a senior vice president as well in the company. She manages a number of state accounts similar to how I do it. She works nationally in a lot of the public sector resource groups like the Public Sector Healthcare Roundtable in Washington, D.C. She works for the State and Local Government Benefit Association doing presentations, a frequent speaker. So I'll let her address it, but she's very well spoken, very well respected in the industry. That being said, Patrick has also been asked to do an additional role. So Patrick is taking on an actuarial leadership role in our region. So he's going to work closely with the actuary that we're adding to the account, which is Melanie Ingleby. So I wouldn't say we're leaving. We're adding additional staff to cover your account like we have. Melanie was the chief actuary for Texas Teachers Retirement System. She's also a vice president, very well respected, very bright. So with that, I'll let Kirsten say a couple words.
Good morning.
Welcome.
Nice to see you all. As Ken said, I've been with Siegel. Well, I've been doing this for 31 years, healthcare actuarial consulting. I did work on this account before in 15 through 17. I've worked with Ken and Patrick for the last 18 years. So even though you haven't seen me, I always know what's going on here as well because we all work together. Myself and Melanie are looking forward to coming in here and being with you all. Just as Ken said, I have over 30 years of experience. I've done Medicare, Medicaid, all kinds of things. I think actually back when ACA came in, I did the projections for the Medicaid expansion population for Kansas with a different role, but happy to meet you all and happy to be involved.
Very good. Thank you for being here.
Thank you.
I look forward to working with you. Yep. And Patrick, if you want to walk up and for the final time, walk us through the financial report.
Yep. Patrick Klein, Siegel. All right. So we have data through October, and the first table we've got our actual to budget. So if you go to the bottom line, the reserve balance, we're projecting a $32.7 million ending balance through October. We closed at 46.3, so that's $13.6 million ahead of what we projected. Now you have to take into account that we had the unforeseen pharmacy settlement of $14.6 million midway through the year that we didn't budget for. So if you take that out, we're really like $1 million below what we initially projected. So on $520 million in spend to the first 10 months, that's relatively close to our numbers. If we look at the various expense items, medical being the biggest expense at $315.1 million. We're actually right on from what we initially projected. Pharmacies, where we have our biggest variation, $3.6 million loss or 3.8%. Dental's fairly close, a $0.6 million loss. And then on the health savings contributions, that's $0.8 million higher than we initially projected. There was a question last time on how much of that is HRA versus HSA dollars. And we did the calculations, and it's 94% HSA dollars. So that jives with what Jennifer reported on the enrollment for HSA versus HRA. And then we have some other fixed fees and accounts, and there's not a whole lot of variation there. So on the expense side, we're $4.7 million behind, and then we had an offset on the revenue where we had a gain. So we net all that out, and we come back to a $1 million loss. So our enrollment, the left column, that's what we set our budget off of. That was at the beginning of the year, the head count. And now that we're through October, we haven't seen much of a change. So there's 20 contract difference, basically the same. There's been a little bit of a shift there's been more non-Medicare retiree contracts and then less Medicare contracts. And then this table, this is our multi-year projection. So we were projecting expenses and revenues out through 2029. And the emerging experience on the medical was positive. So we're seeing a slight decrease when we project those costs out to future years. Pharmacy, we saw that loss. So that accumulates into our baseline projection. So our pharmacy projections are higher. Dental is a slight decrease. When you look at it all together, we're basically in the same spot as last update. So our projected reserve balances through the future years are really, really close to what we presented before. We did add this table at the bottom to kind of hone in on what's going on with the pharmacy. So this is our GLP-1 spend through for 2024 compared to 2025 through Q3. And the top two drugs, again, those are for diabetes. And then the bottom two, Wegovy and Zepbound, those are your GLP-1s for weight loss. And in total, we've seen about $5 million in growth in terms of net spend for 2025. So that's a large driver on our pharmacy trend. And really Zepbound's driving a big portion of it. I did notice, like the Wegovy, you're seeing high utilization increases. So 72% increase in prescriptions, yet the total cost is only going up 38%. So we are seeing some improved pricing on Wegovy. Any questions about?
Any questions, commissioners? Commissioner Decken.
On the GLP, somebody review for me exactly what, we took some action on that. And what impact, if any, have we seen or do we perceive?
That'll be effective at the beginning of next year. So
It hadn't started yet. Okay.
Yeah.
Thank you.
So
Commissioner Sutton.
Thank you, Mr. Chair. I'm pretty sure I asked this last time, but what is it that we're seeing between 27 and 28 that leads to a pretty decent turnaround in our reserve balance?
yeah, I mean, I think it's just the funding is starting to catch up. So you can see that net income, net expense number, you know, it starts to dip down and then you're starting to climb up in 2028.
See, but I thought that the funding level would have already come into play, maybe even for 26.
What's that? So the funding's level, but you can see that your expenses are higher than your revenue now. But as we go further and further out, the revenue at 7.9%, what we're projecting, that's above your cost trends. So it takes a while for it to catch up. In 2027, the expenses, so you can see on this sentence here at the top, that there's 53 medical payments in 2027. So there's some, I guess, seasonality in terms of like the years where 2027 is higher because you have 53 payments and then normally you have 52. So the cost in 2027 is higher than traditionally it would be because you have that extra medical payment in there.
By $17 million? Or $24 million, actually, I guess, net income.
Yeah, I guess, so you can see in 2026, if we start there, you got a $12 million
Right.
deficit, right? A net expense.
Right.
So we move to 2027, it's 7.1 million. If we didn't have that extra medical payment, that would probably be close to zero because we spend about $7 million per week on a medical claim. So I guess if that was a 52-week year, then that would be close to zero. And then you could kind of see that normal progression up.
Okay. Yeah, it's at least mud level clear. Got it. Thank you. Thank you, Mr.
Commissioner Schmidt.
Thank you. I have never thought about it in these terms before, but how are the compounded GLP-1s, where do they come into play here?
Compounded GLP-1s?
Mhm. If a pharmacy is compounding it?
I don't believe the plan's covering compounded GLP-1s.
Okay, so those are all cash only.
Yeah.
Okay. Thank you.
Any other questions, commissioners? All right. Seeing none. Thank you, Patrick, and appreciate your time.
All right. Thanks.
All righty. Commissioners, moving on to just hoping to get settled on a December date. You might recall during our last meeting, we did schedule HCC dates for 2026 for February, April, June, and August. And you can see those on, I don't know, I can't read the page number, so it's tab 6. But we left December open because none of the dates we proposed at the last meeting worked. So hoping the second bite of the apple that we're able to get something that works for the December meeting 2026. And it strikes me as I'm guilty as this as a society. We're all busy 12 months out. So
Still in 2025.
right. So in December, you can see, I believe the columns on the left there are maybe original. So maybe if anything changed, but then we've added some dates. So looking at calendars, we have December 1st, 2nd, 3rd, and 8th for the 9:30 to 11 slot available, or we can move to an afternoon slot, December 9th or 10th.
For me, any of those except for the 3rd would be workable.
The Commissioner Decken is removing the 3rd. Okay. Anybody else see anything that Commissioner Sutton is open the whole time? You're just waiting for us to decide.
Well, except for the only day I can really work the 3rd.
Just looking for a quorum at this point. Yeah, Commissioners, just a moment here. Commissioner Kane, are you aware of any that don't work for you?
I am not aware of any.
Okay. Commissioner Ansley?
So am I, but I still.
All right, fair enough. Commissioner Schmidt?
I think for me, the 1st, 2nd, or 3rd will work, but I don't think after that, those after the 8th doesn't work.
Yeah. Why don't we do this? Why don't we target Tuesday, December 1st at 9:30? Since that's the first one, if something comes up, we have a few fallbacks behind that. So we will set Tuesday, December 1st, 2026, 9:30 to 11 as our December meeting. Thank you. I appreciate everybody's willingness to be able to schedule that far in advance. Only thing left to note is there is the appendix. It's got some follow-ups from the August meeting, answer some questions. I also noted that the annual report is back there. And then I believe we've reviewed this before, but it has a list of contracts that and RPs that we're going to decide on during 2026. So no action, just wanted to make sure that I note that for the commission. Before we close, are there any other questions, comments, concerns? Hearing none, I would entertain a motion to adjourn.
So moved.
Got a motion from Commissioner Decken. This should be the easy one. Second from Commissioner Kane. All in favor, say aye.
Aye.
Any opposed? We are adjourned. Thank you.